Bismillah ar-Rahman ar-Rahim. Today we have our final lecture about the neoplasia topic. And finally, we will highlight some of the diagnostic measures that we can use in order to diagnose cancer. And we will have a little focus on the symptoms and signs that can be seen in cancer patients, and we regard them as red flags in order to diagnose cancer. So, as any disease, the diagnosis of cancer starts with history and physical examination, or history and the clinical examination. And in history, we ask for symptoms, and what the healthcare worker learns from talking to the patient. You ask the patient, what do you suffer from? Do you have headache? Do you have chest pain? Do you have, let's say, problem in your digestion? So those are symptoms. While signs are physical examination of the patient, what you see in the patient when you examine him. Like when you find a mass that may be palpable or visible, you see it or you palpate it. If the patient has fever, which you measure, not the patient feels hot, those are the signs that you discover by physical examination. And the third step always in diagnosis is investigations. And investigations has many types. First of all, we have the radiological techniques or radiographic techniques, including X-ray, CT scan, MRI, ultrasound, or nuclear medicine, which are the radioisotope scan. Each of those has its own use, and in different types of cancers, we can use different types of radiological diagnostic techniques. We have also the laboratory tests. We have general tests like blood picture or CBC, complete blood count. You can check also stool for occult blood, blood sugar, etc. Any usual tests that we do for the patient. And we have also special laboratory tests, including certain tumor markers that are specific for such for certain tumors, or specific test antibodies that can be seen in specific tumors or specific lesions. So let's go to the diagnostic methods that contains that we do in our pathology department. So we have the morphological methods. Morphological methods, we have first the cytological methods. And cytological methods, from its name, means study of the cells. So we have individual cells. We don't have tissue. We don't have tissue, complete tissue. We have only cells. Usually, we can use the smear. Smear, we take like brush or something, and we take part of the, we pass it over the part of the tissue, and we smear it over the slide. So how do we get those cells? Is by multiple processes. Some of them is called fine needle aspiration. When we have like a breast mass, we insert a needle inside it, and we aspirate, and this aspirate is smeared on a slide, and we can see the cells. We have a brush cytology, with like in the bronchial brush, endobronchial brush. When they go inside the bronchus by the bronchoscopy, they have a brush. They can brush the inside area of the bronchus, so we can get cells and smear them and stain them, look at them under the microscope. Fluid tapping, like if the patient is having ascites or pleural effusion, you can tap this fluid, take part of it, and examine it for cells. Usually, we stain those cytology smears by a stain called papinaculous stain or PAP stain, and also we can use the regular H&E, hematoxylin and eosin stain. Now, because of its only study of cells, not the tissue, usually it has high rate of false positive and false negative. Not very high, but some of them can give you a false positive or false negative. So usually we do not rely only on the cytology. We can ask for more invasive method, or for biopsy, so we can see the whole tissue, not only the cells. And this even sometimes, if the cytology is positive, sometimes we ask for biopsy in order to confirm the diagnosis. So this is the morphology that we see in a pap smear of the cervix. You know, in our part of the world, or in every part of the world now, they use the pap smear or the cervical smear for screening for cervical cancer. And you can see here we have, this is the normal appearance. So here we have squamous cells. You see about how abundant cytoplasm it has with a small nucleus. And here we have the endocervical cells, which are a little bit larger with fluffy cytoplasm. So this is the normal appearance. Now, how do dysplastic epithelial cells appear? You know the features of dysplasia. We have talked about them multiple times. You know, we have a nuclear enlargement, high nuclear to cytoplasmic ratio. You can notice how large is the nucleus here. Also, irregular hyperchromatic nuclei with clumped chromatin, which is part of the dysplastic features that can be seen in the epithelium. So once you see this, you think of dysplastic lesion affecting the epithelium, and you ask for biopsy for further confirmation. This is the process of fine needle aspiration. This patient has a breast mass, and you can insert the needle inside the mass, aspirate, and you will get part of the cells or few cells from the lesion. And you examine those cells under the microscope, stain them. If they have atypia or dysplasia, this will result in we will have the diagnosis. The other type of morphological methods is the histopathological methods or histological methods. Now, in histological methods, usually we have biopsy of the tissue. So the types of biopsies include the needle and core biopsy. We took only a small part of the lesion. We have endoscopic biopsy, like we take by endoscopy, upper GI endoscopy. We go into the stomach. We can take biopsy from the stomach, or open surgical biopsy, like if the patient has, let's say, a bone lesion, then an open biopsy will open into the lesion, and you took a biopsy from it. You take a biopsy from it. So those are the different types of biopsies. Now, those biopsies can be examined in different techniques. One of them is the frozen section, which is a very rapid technique that is used mainly during surgery. When the surgeon or the clinicians want a very rapid diagnosis, like in brain tumors, in sentinel lymph node of the breast, the surgeon needs immediate diagnosis, because the surgery will differ based on the diagnosis. So if the patient, let's say, has metastasis in her sentinel lymph node in the breast, so the surgeon will go into axillary dissection. While if the patient or if the lymph node is not involved by metastasis, then there will not be axillary dissection. And this is only used, as we said, when the diagnosis can change the management of the patient. We have the usual way, which is the paraffin section, when the tissue is processed, fixed in formalin, then processed overnight in and embedded in paraffin section, stained by H&E, and other different stains like special histochemical stains and immunohistochemical stains. Now, this process takes 36 to 48 hours or sometimes longer. So the usual way is the paraffin sectioning, which will take longer time, and this you will have the definite diagnosis. So we have the hematoxylin and eosin, which is the usual stain that we use. Then we have special histochemical stains, which we ask based on our diagnostic methods. We have the special histochemical stains like the periodic acid shift stain, Congo-red for amyloid, Pearl's iron stain for iron deposition, or by immunohistochemical methods, which we talk about in the next few slides. So, immunohistochemistry is a method of staining by use of monoclonal antibody directed against virus components in the cell. And the main use of immunohistochemistry is diagnosis of undifferentiated cancers or help in identifying source of a metastatic tumor. So if the patient presented with a lesion or a tumor, and they took a biopsy or do excision of the tumor, and you look at it under the microscope, and the tumor is very poorly differentiated or undifferentiated. So it does not resemble any of the, let's say, does not resemble any of the usual types that we know in our minds. So we need to do special immunohistochemistry in order to classify or to know the type of this type of the tumor from which cell it originates. And we use different types of immunohistochemistry. Also, if a patient presented, let's say, with a metastasis, either to the lung, to the brain, and we do not have where is the primary, we do not know where is the primary site of this tumor. So we use also a special or immunohistochemical stains that can help us in defining the primary site of this tumor. So we have here few immunohistochemical stains that have a very important use in our daily pathological diagnosis of tumors. So we have the cytokeratin immunostain, which is usually positive in carcinomas. So if we have an undifferentiated tumor and it stains positive for cytokeratin, then definitely we will think of carcinoma. We have different groups of cytokeratins, and those different groups indicates different origin of the carcinoma. Like we have CK7, CK20, CK19, CK56, and high molecular weight cytokeratins. All of those are expressed in different types of carcinomas. And this is a little bit advanced, but when you have certain, let's say, immunophenotype for this tumor, this will give us more idea about where is the origin of this tumor. We have an immunostain called LCA, or leukocyte common antigen, which is usually seen in lymphoma. We have the S100 immunostain, which stains neural tissue and melanocytic lesions like melanoma. We have the vimentin and desmin immunostains, which are usually seen in sarcoma. So if I have an undifferentiated tumor, such as this tumor, you cannot tell from the histopathology itself or by the morphology or the immunohistochemistry itself what is the type of this tumor. Is it carcinoma? Is it sarcoma? Is it lymphoma? You cannot tell by precisely what is the type of this tumor. So we need to run immunohistochemistry, as we said earlier. Here we have an undifferentiated tumor that stains positive for cytokeratin. And as we said earlier, staining for cytokeratin indicates that this lesion or this tumor is carcinoma, not sarcoma or lymphoma. Also here we have an undifferentiated malignant tumor, which is, as you can notice, we have atypical mitosis, we have high-grade atypia, and other features of malignancy. So as such, when we have this also undifferentiated tumor, we need to do immunohistochemistry. And here we have vimentin positivity. And vimentin positivity is not that much specific, but it is usually seen in connective tissue related tumors, which are sarcomas. Connective tissue tumors, the sarcomas usually are vimentin positive. Another process that we can use in our diagnosis is electron microscopy. Now, electron microscopy is usually for recognition of intracellular structures like desmosomes or neurosecretory granules, some types of, let's say, lipid droplets, any very small structures that are seen intracellularly that can give us a hint about the type of the cell that we are looking at. Now, electron microscopy is not a practical tool for diagnosis because it needs special that we have to have the electron microscope, which is not available everywhere, and you need special media, special processing techniques for tissue in order to look at it by electron microscopy. It is used in certain types of biopsies like kidney biopsy and other different types that we need electron microscopy. Now, another thing that we usually do are the tumor markers. Now, we have talked about tumor markers in the previous lecture, and we will give more about the tumor markers here. Now, tumor markers are used to identify tumor-associated enzymes, hormones, antigens, etc. And we said that it's like a material that is produced by the tumor cells or stimulated by the tumor cells. So you can, they give us a hint about the diagnosis or the status of the patient. They are used to confirm the diagnosis. Also, they can determine the response to treatment as they are decreasing. This means that the tumor is responding to therapy. And also, they can detect early relapse. So if the patient does not have, let's say, a mass or relapse on the radiology, and you ask for tumor marker, and the tumor marker is starting to elevate again, then you think of relapse. Usually those tumor markers are seen in the serum or in the urine, and many of them are present in normal and in tumor tissue. And as we said, it's the level of that tumor marker. If it's highly increased, this means that we have something abnormal. And also they are not so specific, but the level is important. The level of the tumor markers is important. So what are the tumor markers that we use usually? First of all, we have the hormones. Hormones like the HCG or human chorionic gonadotropin, which it can be elevated in physiological conditions and in pathological conditions. Physiological conditions like in a pregnancy, and it is used for pregnancy test. That's the hormone that is positive in pregnancy. Also, it's positive in gestational trophoblastic disease like choriocarcinoma and other germ cell tumors of the testes. And as we said earlier, the level here is important. So if the patient presents, if let's say a young lady presents as like she is pregnant and the beta HCG was sky high, extremely high, not the usual level for such gestational age, then we should think of tumor or gestational trophoblastic disease. But if it is normal or in the levels that are usual, then this means that there is a physiological process, which is pregnancy. The second type is the oncofetal antigens, like the CEA or carcinoembryonic antigens. This is usually seen in fetal tissues and in some malignancies, including colorectal carcinoma and pancreatic carcinoma. And this, as we said earlier, can be used in detection of relapse or response to treatment. So if we do surgery for a patient with pancreatic cancer, we usually follow him up with radiology. And if the radiology is negative, we usually do the CEA. If the CEA is elevating again, this means that the patient is having some relapse that we cannot see clinically. Also, another type of oncofetal antigens is the alpha-fetoprotein. And alpha-fetoprotein is usually elevated in cirrhosis, which is تشمع الكبد, and it will be extremely elevated in patients with hepatocellular carcinoma. So that's why we follow up the patient who have cirrhosis with alpha-fetoprotein. If the alpha-fetoprotein starts to rise into very high levels, then we should suspect hepatocellular carcinoma. Also, alpha-fetoprotein can be increased in some testicular tumors like the yolk sac tumor. Also, we have the isoenzymes like the prostate-specific acid phosphatase or the PAP. Usually, this enzyme is increased in metastatic prostatic carcinoma. And as we said earlier, it can be useful in staging prostatic carcinoma. So if the patient is having very high levels, this means that the patient has advanced stage, assessment and of prognosis, and also response to therapy. When the patient is having, let's say, chemotherapy or hormonal therapy for treatment, the PAP should be decreasing. If it starts increasing again, this means that the patient is not responding to treatment or the patient is suffering from recurrence or relapse. Another type of tumor markers are the specific proteins, like immunoglobulins, which are secreted in multiple myeloma. Now, multiple myeloma is a plasma cell tumor that usually affect the bone, result in lytic bone lesions and excessive production of immunoglobulins. So the patient will have excessive immunoglobulins in their serum. Also, we have prostate-specific antigen or PSA, which is present in the epithelium of the prostatic duct. Usually, it is increased in prostatic hyperplasia, which is a benign condition, but it will be very highly increased in prostatic carcinoma. And the levels also correlate with the stage of prostatic carcinoma. So if we have excessive or if we have advanced disease, the level of PSA will be very high, while in, let's say, in early stages of prostatic carcinoma, the PSA will be elevated, but not in the levels which is seen in advanced disease. And also, it can be elevated, as we said earlier, in benign conditions like prostatic hyperplasia. So it is important not only to be for the tumor marker to be positive, but also to detect the level, because the level can correlate with the tumor stage and response to treatment and also recurrence. Another tumor markers that can be used are the mucins, like MUC1, or which is from mucin 1, MUC1 in breast cancer. Also, we have the CA125 and CA199, which is seen in ovarian carcinoma, And those also are useful in pancreatic and hepatobiliary carcinomas. So also those will be elevated in pancreatic and hepatobiliary carcinoma. That's bring us back to what we said about tumor markers, that they are not entirely specific. So tumor markers can be elevated in different types of malignancies. Another technique which is used also in cancer diagnosis is flow cytometry. Now, flow cytometry is a technique for identifying cells and their components as DNA by staining with a fluorescent antibody and detecting the fluorescence. Like if we want to detect B lymphocyte, we use the CD20 antibody and we attach it with a fluorescent material. Then we pass the cells through the flow cytometer, and this device will detect all the cells that have this antibody on it, so it can detect all the B lymphocytes. So it can correlate with the rate of growth and the prognosis, and it is very useful in diagnosis and the classification of lymphomas and leukemias. Actually, its main use is to diagnose and classify lymphoma and leukemia. Another also technique in cancer diagnosis is molecular diagnosis, which is really advancing in the last 10 years and will keep advancing in the next years. Now, molecular diagnosis, the methods that we use include PCR or polymerase chain reaction and FISH, fluorescent in situ hybridization. Now, those techniques usually is used to detect gene rearrangement, translocations, amplifications, deletions, and etc. So we have many techniques, and they are a little bit complicated to talk about now. Now, what are the main function? Is to detect genetic aberrations that are usually seen or specific in certain type of tumors. Like we have the translocation in CML or chronic myeloid leukemia that combine BCR, ABL, translocation 922. So with those we can detect by molecular techniques. Monoclonal proliferation of B or T cells, like we do the T cell receptor rearrangement studies or clonality studies. So we detect that we have expansion or clonal expansion. This is seen is in lymphoma. Also, we have 13q14 deletion in retinoblastoma and many other molecular aberrations that can be seen or specific to certain types of cancer. Now, molecular diagnosis is very important and is trending now because of its specificity. We can detect the very specific mutation that is very specific for certain tumors. And also, it can give us a hint when we have a very undifferentiated tumor. So, also, it can be used for a prognosis, like in gene amplification. HER2 in breast carcinoma, we can detect it by immunohistochemistry, and also more accurately by FISH, fluorescent in situ hybridization. Also, NMIC amplification in neuroblastoma, which is very important in the prognosis. Also, it can detect residual disease, like in chronic myeloid leukemia. We do the cytogenetic studies, and we see if there is remaining cells with this translocation. Also, detection of genes with hereditary cancers, like BRCA1 in breast cancer, and they are very useful in targeted therapy. So we can design drugs that can attack the cells with certain genetic aberrations or can destroy the protein that results from such mutations, resulting in damage or targeted therapy against the tumor cells. So molecular profiling of tumors is useful, as we said, in targeted therapy. Now, by molecular, we can identify thousands of genes from tumors and give the cells their own identity and fingerprint, and may give important diagnostic information as well as guidelines for therapy. So it's like an identity of the tumor cell. So we can give the drugs or the treatment modality this identifier, so they can detect the tumor cells and attack them specifically. So some say this may replace standard histopathologic identifications of tumors. So this is the usual histopathologic classification by an immunohistochemistry, and sometimes you can do the molecular profiling. Molecular profiling can be done on the tumor itself, on the sections, or sometimes now new techniques by blood. You take blood from the patient, which contains sometimes tumor cells, or you do the full molecular profiling, and this will give you a very detailed idea about the tumor and about the targeted therapy against such tumor. Now, the most important thing to talk about in all these lectures is the early diagnosis of cancer. Now, as you all know, if you detect cancer in its early stages, the rate of cure will be very high. But if the cancer is advanced and metastasizing in the body, then the rate of cure will be much less, with a very bad prognosis. So our job as physicians is to increase the early detection of cancer by educating the population, giving them ideas how to detect cancer early by examining themselves or having been examined by the the physicians, especially after certain age, which we call the screening methods. So this is really the most important thing in our part of the world. We need to detect cancer as early as possible in order to increase the cure rate and increase the good prognosis in our patients. So specific symptoms should be followed up. So those symptoms, we call them red flags. Red flags. So we should educate the general population about those symptoms, and if anyone develops such symptoms, they should seek medical care and look for help. So the symptoms are abnormal bleeding, change of voice, when the patient has hoarsening of voice, which can be a sign of tumor of the larynx, change in a nevus, if the patient has a nevus اللي هي شامة. If the patient has change in this nevus, this might represent melanoma or something. Abnormal lump in the breast, that's why we teach patient to do self-examination of the breast, so they can detect if there is a mass. An ulcer that does not heal on the skin, this might be a sign of skin cancer like basal cell carcinoma or others. So many symptoms. Those are only examples of symptoms that we should always be aware of, and we should always teach our the population about these symptoms and when they need to seek medical advice. So also one of the processes that prevent or helps in detection or early detection of cancer is like self-examination of the breast, mammogram, which is one of the screening programs that are present in our country. All the females above the age of 40, they should do mammogram in order to see if there is any changes related to breast cancer. Serial pap smears of the cervix, which can detect cervical cancer. Serial sputum cytology in smokers. This usually can detect the changes in the lung cancer very early. Serial urine cytology in some cases, like in bilharziasis, workers in rubber, which, as we said earlier, those patients have high risk of developing bladder cancer. And also we have screening for genetic mutations in familial cancers. So if the patient has, let's say, breast cancer in their 20s, this means that this patient has some genetic abnormality. And we need to test her and test her family for such genetic mutation that has high risk of developing cancer. So patient who, like, let's say, who has BRCA1 mutation, they are at very high risk of developing breast cancer. And such, they can have protective measures by doing, let's say, bilateral mastectomy and for prevention of development of cancer. So this is the mammogram, as you can see. It's a simple X-ray. So fight cancer by awareness and early detection. That's the take-home message from all these lectures. We need always to educate our population, detect cancer early for more cure. Thank you very much.